Good morning. Thank you, Dr. Badr, for that very kind introduction. I'd like to thank AbbVie for allowing me to speak on their behalf in the Satellite Symposium. And also I'd like to thank the SGA for this wonderful conference. It's always a pleasure to be presenting here among friends and colleagues. So my talk today will be focusing on risankizumab in the treatment of moderate to severely active Crohn's disease. So we'll start with a brief introduction. This very famous figure, as we all know, tells us that both ulcerative colitis and more so Crohn's disease are considered progressive diseases. As you can see, the repetitive cycles of inflammation and periods with persistently active disease ultimately to complications which require surgical intervention. The idea is that if we are able to suppress these cycles and prevent periods of active disease, we would be able to prevent the development of complications and ultimately prevent the need for surgical intervention. However, this necessitates that we intervene before complications occur during periods where the phenotype is purely inflammatory, and this is a period that we call the window of opportunity. So as physicians, we'd have to be able to identify patients at risk of adverse outcomes as early as possible, start therapies that are appropriate at the right time with the right dose, and be able to monitor patients closely to prevent unrecognized inflammation. Now, how do we do that? We follow the treat-to-target strategy, a well-recognized approach that is more or less standard of care nowadays. We follow the STRIDE-2 recommendations that include short, intermediate, and long-term targets to ensure that there are no periods where the disease is active and to be able to ensure tight control of the disease. Now, this did not happen randomly. This is something that is a result of the evolution in these endpoints over a long period of time, where we went from following clinical parameters that are more subjective to relying on objective markers of inflammation. So we moved from looking at clinical response, clinical remission, to endoscopic outcomes such as response and remission, and finally, more evolving concepts such as endoscopic or let's say mucosal healing, histendoscopic mucosal improvement, and transmural healing as well. Now, these are the approaches. This is the concept, but at the end of the day, what we need to do is choose a medication that fits within this approach. So there's a wealth of medications available now in 2024, but the idea of being able to tailor therapy towards the patient's needs is based on our ability to look at different parameters and characteristics such as disease severity, disease location, complications of the disease, and risk of progression, and be able to make the most acceptable judgment in choosing the medication for treatment. Now, another point is that we have to be able to compare between these agents and make the most sensible decision as to which is more appropriate in such a situation. So the comparative studies available for us out there include head-to-head trials, which we're beginning to see more and more in IBD, real-world studies, and different types of meta-analyses. So through these different types of comparative studies, we'd be able to make the most appropriate evidence-based management decision. So let's look at the extensive clinical trial program over the past decade involving risankizumab. So if you can see the timeline here, this started back in 2016 where studies for plaque psoriasis started, and eventually in 2019 the drug was approved for plaque psoriasis. Around the same time, studies for Crohn's disease started, phase 3 studies and also studies for psoriatic arthritis. The drug was then approved for Crohn's disease in 2023 for moderate to severely active Crohn's disease and also for psoriatic arthritis in 2022. Now, during this period in 2020, a very important head-to-head trial, which is the first trial to compare risankizumab with another drug, ustekinumab, for moderate to severely active Crohn's disease, was started and eventually published in 2024. In this study, clear superiority was demonstrated for risankizumab over ustekinumab with regards to endoscopic outcome as a primary outcome. And we'll talk more about this. So I'll be talking now about this study, which is sequence. First, let's go over the pathophysiology or mechanism of action. So anti-IL-23 specific antibodies, such as risankizumab, inhibit IL-23 interaction with the IL-23 receptor without blocking another pathway which is closely involved, which is IL-12, and involves the Th1 pathway. So this idea is very simple. There is a heterodimer, which is P40, which is shared between IL-12 and 23. There's also another protein receptor, which is P19. When inhibited, only leads to inhibition of the IL-23 pathway, which when activated through TYK2, JAK2, and STAT3 leads to activation of the Th17 pathway and the production of numerous pro-inflammatory cytokines leading to leukocyte migration and innate immune system response activation. So ustekinumab, which works on the P40 heterodimer, when it blocks P40, leads to inhibition of both pathways, which is IL-12 and 23. So far, there's multiple IL-23 inhibitors or P19 inhibitors that have been developed and licensed for different indications. However, so far, the only drug that is approved and commercialized for Crohn's disease here in the kingdom is risankizumab. So this is sequence, which is the first head-to-head trial to compare risankizumab with ustekinumab in Crohn's disease. So it is a phase 3b open-label study. It's multi-center randomized, and it's very important to acknowledge that here the efficacy assessors were actually blinded during the study. So here risankizumab was compared to ustekinumab for the treatment of adult patients with moderate to severely active Crohn's disease who had previously failed anti-TNF therapy. So you can see at the beginning, patients received induction therapy, so they either received risankizumab IV, dose of 600 milligrams at weeks 0, 4, 8, or ustekinumab, standard conventional dosing according to weight, IV. And then at week 12, patients continued on to have maintenance treatment. So for risankizumab, it was subcutaneously 360 milligrams every 8 weeks, and ustekinumab, it was subcutaneously 90 milligrams every 8 weeks. The study continued for 48 weeks. If you look at the baseline characteristics, you can see a very balanced distribution across both groups with regards to the patients enrolled in each arm. Now, this is the endpoints of the study. So we have two types of endpoints. We have superiority endpoint and a non-inferiority endpoint. So the non-inferiority endpoint was clinical remission at week 24, and it was based on a non-inferiority margin of 10%. And you can see that here the endpoint was met statistically significantly, which was the p-value is less than 0.01. On the right side, you can see the superiority endpoint, which was endoscopic remission at week 48. And again, you can see it was in favor of risankizumab over ustekinumab, statistically significantly. The p-value is less than 0.001. So you have a delta of about 16%. Then you can see on the further right, ranked secondary endpoints, all in favor of risankizumab over ustekinumab. with statistically significant p-values observed across the board. So you have endoscopic response at week 48, endoscopic response at week 24, and steroid-free endoscopic remission at week 48 as well. If we dig a little bit deeper and try to stratify patients according to their disease location, on the left side you can see CDAI clinical remission at week 24 based on the patient or the disease location, and you can see there's statistically significant difference observed once the colon is involved, so either colonic or ileocolonic disease. On the right side, you can see that there's no difference when you look at endoscopic remission at week 48 at the end of the study. So no matter what the disease location is, risankizumab scored better than ustekinumab with p-values statistically significant in all outcomes. It's very important to look at clinical endpoints. So we have here CDAI clinical response, CDAI clinical remission, and PRO clinical remission. And you can see separation in the curves early on in the course of the study. So as early as prior to week 8, there's clear separation and superiority observed for risankizumab over ustekinumab for all 3 outcomes and persistently throughout the different times of the trial. If you look at endoscopic and composite endpoints, endoscopic remission was higher in patients who received risankizumab, and so was mucosal healing at both weeks, week 24 and week 48. Now, it's one of the endpoints we look at is biologic remission. So we look at normalization of biomarkers. And again, you can see how as early as week 8, we begin to see separation between the 2 groups in favor of risankizumab, and deep remission on the right side at both weeks 24 and 48 was reported higher in the risankizumab group compared to the ustekinumab group. So these are just some demonstrations of the curves of CDAI, CRP, and fecal calprotectin trends starting from baseline all the way to week 48. And again, you can see superiority observed in risankizumab over ustekinumab. So this is an abstract that was published last year. So what they did is they looked at hospitalization related to Crohn's disease, and the incidence rate over 48 weeks was lower for risankizumab compared to ustekinumab. Now, this difference in hospitalization resulted in an annual healthcare cost saving of $230,000 per 100 risankizumab treated patients. And as you can see on the right side, the difference was statistically significant with regards to this outcome. Now, this is a very safe class of medications, and it has consistently been observed that there is no real signals of concern in all trials of IL-23 inhibitors. And again, in this study, you can see that the safety profile of both drugs are consistent with previously published results. Now, this is not the first study to compare these 2 drugs. There has been a prior comparison in plaque psoriasis where you could observe again superiority of risankizumab over ustekinumab as early as week 4 and continuously seen all the way to 52 weeks or 1 year. And you can see this is using the most stringent plaque psoriasis outcome measure, which is the PASI 90. And what this tells us is this extends beyond the gut, and there's clear durability with these medications. You can see at the end of 1 year, 81% of patients in the top had PASI 100, and in the bottom, about 60% demonstrated, PASI 90, and in the bottom, about 60% demonstrated even a more stringent outcome of PASI 100. Now, you cannot talk about risankizumab without mentioning or going over the pivotal trial where risankizumab was studied against placebo. So this is the clinical trial program for risankizumab and Crohn's disease. So we have 2 induction studies, Advance and Motivate, where following induction responders were re-randomized into the maintenance part, which is Fortify. And here we have a very difficult endpoints, which is co-primary endpoints of endoscopic response at weeks 12 and 52, and clinical remission according to CDAI at weeks 12 and 52. Following maintenance, we have the long-term open label part of the study, which is 45, which continued to 152 weeks of observation. So if you focus on the open label part, you can see on the right side that a very large proportion of patients demonstrated endoscopic endpoints at the end of this open label phase. So you have endoscopic response data reported in 77% and clinical remission data reported in 80% after 152 weeks. You can also see that these endpoints seem to increase with time, starting at the beginning of an induction, going through maintenance, it keeps going up, and then with time, at the end of the open label phase, you can see how it peaks. Again, this is a demonstration of endoscopic remission during induction maintenance in week 52, again reflecting what I just mentioned and telling you that this is probably a cumulative results that improves with time. Now, one important observation from Fortify, if you look at subgroup analysis, is that patients who are bio-naive definitely do better compared to those who are bio-exposed. You can see higher rates of clinical remission, endoscopic response, and endoscopic remission observed in those who are previously naive to biologic therapies. Again, talking about safety, the pooled induction trial and Fortify safety data did not lead to any signals. So I'm going to end my talk going over a real case that I followed up in my own clinic. This is Mrs. A. She's a 28-year-old female diagnosed with severely active ileal Crohn's disease in July of 2024. So the patient in July reported on and off bleeding, perectum, chronic persistent diarrhea with recurrent mouth ulcers. A colonoscopy was done, showed TI stricture and ulcerations. Biopsies were taken and showed evidence of chronic terminal ileitis. She also had an MRE at baseline in August, showed terminal ileal wall thickness with evidence of anterior enteric fistulae. The disease appeared active in nature and there was no other skip lesions. So this patient was naive to any treatment. Her brother had ulcerative colitis. She's a non-smoker and married with no children. Following the diagnosis, she was started on risankizumab induction, 600 milligrams, weeks 0, 4, 8, and then she was switched to over-the-body injector subcutaneous treatment of 360 milligrams every 8 weeks for maintenance. I followed her up closely in my clinic, and as you can see, these are the baseline parameters. So she had this these endoscopic findings translated into an SES-CD of 18. This is the MRE showing the active disease in the terminal ileum with multiple anterior enteric fistulae. So before treatment, she had 6 bowel movements, which were bloody. She had abdominal pain, on-off rectal bleeding. Her CRP was elevated and her calprotectin was 2,654. This was in July. 6 months later, when I saw her, her bowel movements had went down to 2. She had no pain, no bleeding, no further weight loss. Her CRP normalized and her calprotectin went down all the way to 143. So this all shows that in real life, this medication leads to very fast and good results. So risankizumab is indicated for the treatment of adults with moderate to severely active Crohn's disease. This provides clinical endoscopic endpoints aligned to STRIDE 2 recommendations. Endoscopic response is a co-primary endpoints in pivotal trials, including mucosal healing. There's also clear durability. We do have superiority data over another medication, which is ustekinumab, and we have a very clearly well-established safety profile. So these are the indications where this medication is approved. So for Crohn's disease, plaque psoriasis, and for psoriatic arthritis as well. This is the dosing schedule for risankizumab in Crohn's disease. So we have 3 IV infusions at weeks 0, 4, and 8, 600 milligrams, given over 1 hour. And for maintenance, there's only 6 subcutaneous doses per year, so 360 milligrams using an over-the-body injector. That's the end of my talk. I'd like to thank you very much for your attention.